event. I'd like to welcome all of our guests tonight. We truly hope you are healthy and well, and it's very good to see you. We started this speaker series about 5 years ago in person with the goal of bringing our community together on really important healthcare topics. We've watched it grow. We are incredibly proud to see our attendees who were coming in person pivot to this online format. And we're also really proud to be offering live content to our community now in a time where many feel isolated and stressed. I think that connection to people and learning and community are especially important in difficult times like this. I'd also like to give a special hello and warm welcome to all of our students tonight that are joining us. In addition, I'd like to thank my co-hosts tonight. First, I'd like to thank Dr. Jeff Talbot, who will be speaker, and I'll be introducing him in a moment. I'd also like to thank Craig Fraley from Clark County Credit Union. Without Clark Credit Union's support of the Neighborhood Health Series, it may not have been as successful as it has been. So we're very, very grateful. I'd also like to thank ASL Communication for your service tonight, especially Samantha Steed, who's interpreting for you tonight. And I'd also like to thank Cameron Heyman from IT, problem solver extraordinaire, who makes all of this go very smoothly. Please note in the bottom of your screen, there is a chat and question and answer box. If you have questions throughout this presentation, please feel free to enter that into that bar at the bottom, and we can stop along the way or afterwards to answer some of your questions. So with that, I'd like to go forward and introduce our speaker. Dr. Jeff Talbot is the Vice President for Research and Dean of the College of Graduate Studies at Roseman University of Health Sciences. Dr. Talbot received his BS in biochemistry from the University of Nevada before earning a PhD in pharmacology from the University of Nebraska Medical Center. Prior to joining Roseman, Dr. Talbot served as National Institute on Drug Abuse Research Fellow, at the University of Michigan Medical School and as an associate professor at Ohio Northern University College of Pharmacy. Most recently, Dr. Talbot served as Assistant Dean for Research and Faculty Development at the Roseman University College of Pharmacy. His research interests focus on drug discovery in substance abuse and psychiatric disorders. Please join me in welcoming Dr. Jeff Talbot.
Thank you, Vanessa, for the warm welcome, and a very sincere thank you to all who are joining us this evening. Amidst all the craziness of COVID, I'm grateful that we have the opportunity to connect together as a Roseman community and family. It's important for us, I think, to be and to feel connected. A very hearty thanks to Craig for sponsoring this and many other events that have benefited our Roseman communities in Nevada and Utah. And with that, Craig, if you have any words that you'd like to share before we get going.
Thank you, Doctor. Clark County Credit Union is very proud to help sponsor the Roseman Neighborhood Health Series. Thank you to Vanessa for putting this all together. Thank you, Dr. Talbot, for being here to make the presentation even possible. If you should find yourself needing financial wellness, Clark County Credit Union is here for you, as we have been since 1951. Please visit us at ccculv.org, or you can call us 24 hours a day because we're open on the phone 24/7 at 702-228-2228. And thank you very much. Have a wonderful, safe evening, and back to you, Dr. Talbot.
Thank you, Craig, and thank you again for the support that makes this possible. It's a pleasure to see all of you this evening as we meet together virtually. I was asked to speak on this topic of how opioids became a public health crisis. As we go through, the next hour or so together, I'm going to touch on some specific topics. Certainly, we'll talk about where we are as a nation with respect to the opioid crisis, the current scope of the problem within the United States. But before I touch on that, I'll really go back and look historically at the origins of the crisis. How did we get here? What caused us to get here in the first place? It's a fascinating story, and it's wrought with tragedy, unfortunately, but there are some lessons to be learned there. So I am a scientist. This is a talk that is intended to be understandable for all of us, for a lay audience. I'll really work hard to do that, but I'm going to sneak in a little bit of pharmacology and even neurobiology to help us understand how opioids do what they do, why it is that we have this problem to begin with. And then lastly, this is an evolving crisis for the United States. Certainly the entrance and predominance of fentanyl in escalating the incidence of opioid-related deaths in the United States, what's now being called the third wave. So I'll talk about how this is an evolving crisis, and I'll conclude with referencing a little bit of the medical community's response to this crisis, including Roseman researchers that have been working here in Nevada in ways that are very significant and significant to me. So with that, let's begin at the beginning. This looks not too ominous, does it? Right? It's an otherwise beautiful and harmless picture that depicts, unfortunately, the origin of what now has become a global health crisis. On the left, you see a beautiful flower. It's the flower from a plant called Papaver somniferum. Several times a year, on the right, what's shown is the unripe seed capsule of that flower. Several times a year, workers will go into fields and they'll score the outside of the seed capsule, and a white milky substance will flow out. That's called an exudate. That exudate is collected and dried, and that dried substance is what we call opium. This is the opium poppy. The opium poppy plant produces a number of psychoactive compounds, these compounds that alter brain activity and affect the body. The major compound in opium is morphine. It can be as much as 12% of the opium product itself. Just as a fun fact for this evening, the Greeks call that dried substance meconium. It literally is interpreted as opium-like. And of course, for the parents in our virtual room tonight, you know that meconium is what we refer to as a newborn baby's stool, only because that opium dries to a yellowish color. If we walk down memory lane a little bit and look historically, the properties of opioids have been known since antiquity, or as my kids would say, like forever. 5,000 years ago, we can look back and see the first reference to using opium in a text, Homer's Odyssey. So for thousands of years, opium was cultivated and grown through lower Mesopotamia. The Sumerians called it the joy plant. It was recognized for its medicinal and its recreational purposes. So they used it to treat maladies at the time, fever, the pain associated with that. They would use it to treat cough, for example, but they also used it to get high. Fast forward all the way into the 1800s, 1806 is when we first really recognized what it was within opium that caused these effects. Morphine was isolated by a German chemist. He named it morphine after Morpheus, the Greek god of dreams. The next stop on this historical journey is really 1853, and it wasn't directly related to opium per se, but the hypodermic syringe was invented. A tremendous medical discovery. The problem is that with the ability to inject morphine directly into the bloodstream, it allowed the drug to enter the brain more quickly, which intensifies the euphoric experience of the user, the high that we associate with it. Now, with that invention and escalated use, with the isolation of morphine, abuse of opioids increased. So chemists began to look at ways to change morphine chemically to make it less addictive. So some clever chemists from the Bayer Corporation, again in Germany, they attached a couple of methyl groups to morphine. They called it diacetylmorphine, and we call it heroin. Mission not accomplished. They did not achieve making a less addictive morphine, but it was sold and marketed as less addictive, unfortunately, for a number of years. It was then another 100 years until the brain chemicals, the chemicals your brain makes, we call them neurotransmitters, were isolated that are your body's way of making morphine. In fact, it's called endogenous morphine. Your body doesn't make morphine per se, but it's the chemical neurotransmitters within the brain that have morphine-like effects. And then finally, in 1994, the molecular target of opioids was discovered or cloned. Two researchers at Johns Hopkins went on to win the Nobel Prize for that work. So with all of this history, really in more modern times through the 17 and 1800s, morphine and heroin containing products were just widely used and heavily marketed. And you can see on this slide many of examples, whether it's elixirs, syrups, drops, powders containing these opioid products. They were very popular, and why wouldn't they be? One of the most popular you'll see in the upper part of this slide, Miss Winslow's soothing syrup. Yes, Mrs. Winslow, when you give your children heroin containing products, it does sedate them, and not the best thing for teething kids, but nevertheless, it was popular for a variety of reasons. And one of which is this was an era of a lack of regulation. So in modern terms, we would call these many different products OTC, or over-the-counter products, which means you don't have to have a prescription to acquire the product. You don't have to have a physician or a health professional's supervision to use the product. And maybe most importantly, you don't need, the producers weren't required to disclose on a label what the ingredients were to their product. And so many of these things were sold as sort of naturopathic cure-alls. The use escalated all the way into the Civil War, where after the war, soldiers who were suffering from opioid dependency became known as a soldier's disease. So now we're really headed with a full head of steam toward our current crisis. You begin to see it take shape. And again, there are lessons that we can learn from this. During the late 1800s, there was this sharp rise in opioid addiction, and really it had to do with access. We know that morphine was widely available. It wasn't regulated. Again, that OTC means you didn't have to have a prescription to obtain it. Heroin was introduced into the mix. In fact, opium imports peaked into the United States in the 1890s. So with increased access came increased abuse and addiction, unfortunately. What we seem to continue to do in modern societies is react to that increase in abuse. And really the early 1900s saw that reaction be increased in enforcement and unfortunately stigma. A couple of examples here. So the Opium Exclusion Act outlawed imports of opium into the United States. That was 1909. The Harrison Narcotics Act for the first time required a prescription to obtain an opioid containing product. So you see this reaction that's understandable to try and control or get ahead of this increased abuse. But really the seeds of our current crisis, you can look back to the roots of that right here. What this resulted in through the 1930s into the 1970s was a period of what's known in the literature as opioid phobia, a real legitimate fear of using opioids and having the users develop addiction disorders associated with it. The byproduct of that is that pain began to be undertreated because of this fear. And in fact, it was exacerbated somewhat because of soldiers returning home from World War II, from Vietnam. So if we continue down this path, now it's accelerating. The 50s through the 70s saw synthetic or semi-synthetic opioids be FDA approved and introduced into the market, like oxycodone, hydrocodone, or Vicodin, for example. And then during the 80s, such a significant period of time where as a society and to some extent a medical community, there was a focus on the undertreatment of pain. In fact, the American Pain Society started their Pain as the Fifth Vital Sign campaign. There are examples of clinicians who faced litigation for not both civil and criminal for the undertreatment of pain, as well as the risks of being known as inhumane for not appropriately treating pain. And then finally, to cap all this off, in the 1990s is when we saw a renewed heavy marketing of opioids, and Purdue Pharma is the company that we would look to as a culprit in this area. And now we know that there's some civil and criminal liability there with that company. But what's ironic to me is that we are now, as a society, certainly here in the US, beginning to repeat mistakes. These 1990s might as well have been the 1890s that we just talked about. Marketing opioid products as non-addictive or less addictive. We know that there was some fraudulent intent that went into that. That's been documented. But also there was some, at least at surface level, some scientific hope that extended release formulations would lessen the ability of a user of an opioid to become addicted. And of course, you know, what we'll talk about tonight is the actions of addicts sometimes don't make sense. What addicts quickly learned is even extended release formulations, those pills can be crushed and the opioid used in a way to create that high or euphoric experience. So again, here's these culmination of factors that really lead to that perfect storm, where through the 1990s right into the 2010s, a massive increase in the prescription of opioids and the consumption of opioids globally, but also in the US. So this figure here on the left is the total number of prescriptions in millions, so we're talking as much as over 200 million prescriptions for opioid products. On the x-axis is just by year, so it's increasing time. So we're going from 1991 all the way to 2010, and you know, we can all read that during this period, the number of opioid prescriptions increased tremendously. On the right side of your screen, you'll see some of the specific products: morphine, hydromorphone, which is dilaudid, fentanyl, which we'll come back to, and particularly oxycodone or Oxycontin. So these are, this perfect storm has led us to the current crisis that we are in. And so, you know, borrowing statistics from a number of governmental sources, this opioid epidemic is truly staggering. This top left statistic is where we are reminded that numbers can't fully quantify the human cost of this opioid epidemic or crisis. 130 people die every day from opioid related drug overdoses. It's become one of the leading causes of death pre-COVID for Americans. In fact, on that point, in 2015, the US reached a really grim milestone. For the first time in nearly 100 years in 2015, the average life expectancy of Americans began to decrease. And at that time, the overdose of opioids is credited to be a main cause for that effect. And then you look at just some of the scope of the problem in the United States, 10.3 million people misusing prescription opioids in 1 year alone. Nearly 50,000 Americans dying from opioids. That number has increased. 2 million people having an opioid use disorder that is meets clinical criteria. 2 million people using prescription opioids, misusing prescription opioids for the first time. These numbers are staggering, and we can go through them, but I want to draw your attention lastly to just a couple. So the number of deaths that are attributed to heroin is just 16,000, and that's in a period ending in February of 2019. But now we're beginning to see this shift, and I'll come back to this later in the talk, of nearly twice as many deaths that are attributed to synthetic opioids other than methadone. And really this is getting to the third wave of the fentanyl crisis. So you can see again that these numbers are staggering, and I like to remind myself that this matters. That I think many of us listening tonight have had family members or friends who've been affected by this crisis in terms of the quality of life, at times criminal activity, or worse yet, to the loss of life. A close friend of mine 4 years ago lost his life in an opioid overdose. So there's our crisis. It's where we've been, how we got here. And now to really address that question, why and how do opioids do this, we need to sneak in a little bit of science. What's the root of the problem? The pharmacology of opioids. Pharmacology is just a term that describes really the actions of a drug on the human body. What's the effect of the drug itself? So I'm going to spend just a few minutes going through some of these actions in terms that I hope, again, that we can all understand. So just a little tiny chemical structure that has such significance is bringing about this crisis. Opioids mimic the properties of these naturally occurring brain chemicals, these neurotransmitters. I've given an example here on the left. One is metenkephalin. Now there are many, many different types of neurotransmitters that are what we would characterize as opioid-like: endorphins, enkephalins, dynorphins. Some of these you're probably familiar with when people describe, a runner's high. And on the right, you'll see the structure of morphine. So just comparing just these two, metenkephalin and morphine, what you'll notice is that there's some structural similarities. In fact, this bridge across this peptide bond here in metenkephalin, again, this is a compound or a chemical your brain makes, looks just like this bridge structure in morphine itself. So each of you have been taught tonight just a little bit of medicinal chemistry. We refer, in fact, in a medicinal chemistry way, this structure is associated with activity in producing opioid-like effects in your body. It's not the only structures that do it, but it begins to teach us that principle that there are substances that can be made or grown that affect the body in that way.
Dr. Talbot,
Yes?
we have a question.
Oh, good.
Okay, so a couple slides back when you were showing some data, the question is the data that you are sharing from 2019? When is all this data? What
Yeah,
year?
it's a combination. No, great question. Thank you. It's a combination of data from 2018 and 2019. So within those or portions of those calendar years. Of course, we don't have 2020 data yet. So these data here are some of the most recent data that we have. Great question.
Thank you.
So we know that there are chemicals that can produce opioid-like effects in the body. The reason they do that is that those chemicals, these opioids, activate molecular proteins in the brain called receptors. These are the molecular targets of these substances. The most common molecular target or receptor for the opioids is known as the mu opioid receptor, or mu-OR. There's a simple cartoon that's shown here on the left of the slide. This is a barrel-like structure that rests on the outer membrane of nerve cells or neurons. And its job, if we were to say it that way, is to allow that nerve or that neuron to respond to a signal from outside of the neuron, and it allows it to react. In this cartoon, what's shown here is a simplified opioid molecule. Let's pretend that's morphine. It travels into the spinal cord and brain, binds to that receptor, and then produces changes inside of the neuron that cause the neuron to act differently. In fact, opioids are CNS depressants, which means they reduce the activity of neurons in the central nervous system through a variety of changes that aren't important. But on the right side, you can see how that might have an effect. And in fact, what's shown in this simple cartoon is how an opioid, like morphine, binding to a mu receptor on a neuron can result ultimately in the release of dopamine. And I'll come back to why that's important in a few moments. So we have these substances, both that your brain makes or others that we can introduce into the body. They bind to these molecular targets, these receptors, and invoke changes. The expression of these receptors are just exquisite. And just a very brief mention from some work that I did earlier in my career. What you're seeing here is these are sections or slices of a brain where we've used a specialized chemical that has a radioisotope attached to it, where we allow it to bind to the brain anatomy. And the only places that it significantly binds is where the mu opioid receptors are located. And what you can see here is in postnatal development or in adults, the binding of, or rather the expression of the receptor is so exquisite and elegant within the central nervous system where these opioid receptors are expressed. Where they are expressed within the central nervous system determine their effects. And this is a very simplified schematic to illustrate that. Again, this is opioid pharmacology. The reason that we usually take these drugs from a therapeutic standpoint, a medical standpoint, is to produce pain relief or analgesia. And again, that's the result of these medications traveling to the central nervous system and acting in the brain to reduce your ability to perceive painful stimulus. But we also know that through the use or at times misuse, overuse of these medications, we can become dependent on them. Or at times overdose these drugs, as we, I think, have talked about and all know, can cause fatal toxicities through respiratory suppression. So some of the major pharmacological effects of opioids, what we call antinociception, which is pain relief, allows us therapeutically to use these drugs as analgesics or pain relievers. As it turns out, opioid receptors are also expressed in the gut, in the intestines, and they slow down muscle contractions in your gut. So opioids can cause constipation. So we can use opioid drugs as anti-diarrheal medications. And then also they're used or rather they suppress the cough reflex. So we can use them as antitussives or cough suppressants. Now, these are therapeutically useful effects that we can use to treat a number of different types of symptoms or illnesses. The problem is that some of these aren't always great. The constipating effects of opioids can be very, very severe, even leading to bowel obstruction, which can be a significant issue for patients who are using opioids chronically, for example, a cancer patient. There are other effects. Opioids are really good at causing nausea and vomiting. They also cause histamine release within the body, so it can cause itching. In fact, you'll often hear people say that they are allergic to opioid drugs like Vicodin or OxyContin, and the true incidence of an allergic reaction to an opioid is very rare. Most often it's people responding to these natural effects of the drugs where they get sick, they get nauseous and sometimes throw up, or they get itching. It's not an allergic reaction, it's just pharmacology. And then lastly, I've included here euphoria and respiratory suppression. From a true medical standpoint, we really don't have a good use for these. It's strictly speaking, euphoria is the high or the rush that opioid users experience when they take the drug at higher doses. And this really forms the basis for the abuse or misuse of these medications. And then respiratory suppression, this is kind of the business end of opioids, unfortunately. As I mentioned, opioids are CNS depressants. They decrease activity of neurons in the brain, of nerve cells in the brain. Where these receptors are expressed, the mu opioid receptors are expressed in the brain, control your brain's respiratory function, or rather your brain's control of respiratory function in the body. And so taking opioids at higher and higher doses can lead to decreased breathing all the way to completely suppressed breathing and death. So when a person overdoses on opioids, it's because of this respiratory suppressing effect. Now, opioids used in medicine, this is a list that many of you are probably familiar with. If you've had a root canal, your wisdom teeth out, if you've had minor at times or maybe major operations, if you've had a broken bone, chances are that you've had an opioid pain reliever that has been prescribed to you. Some of these are more common than others, and it's really not terribly important that we talk about it, but pain relief is the main reason that we use these drugs. I've noted here Imodium AD, an over-the-counter medication, doesn't require a prescription, is actually an opioid drug that's just as powerful as, say, morphine, but it's not regulated in the same way because this drug, Imodium AD or loperamide is the drug name. It doesn't get into the brain in the same way that these other drugs do that control pain. So you can see many medications that we're all familiar with just as consumers, really. So that's sort of a brief crash course into opioid pharmacology. But if only we could stop there when these drugs are, these medications are useful and helpful to relieve pain and suffering and perhaps treat other maladies that we experience. It just isn't. These are pictures that depict people that are engaged in actions that harm themselves, that so often harm other people. And it is the result of some of the, at times, unwanted effects of opioids.
Dr. Talbot,
You're back.
I'm back with a few questions about Imodium.
Excellent.
You don't mind. So the
Not at all.
questions are, is Imodium typically abused, and can Imodium cause the same euphoria as other opioids that you reference?
Right. It's a great question, and the real brief answer is no. Its abuse liability is almost negligible, and for the main reason that all of these other drugs that we can use for pain relief and other things, and they also can cause a person to have euphoria. They do a really good job of getting into the brain. And loperamide or Imodium just does not. And that's the main reason. So there were two questions. One is that can it cause euphoria? And really the answer to that question is no. And what was the other question?
Can it be abused? Is there potential for abuse?
No. In strictly speaking, no. And certainly not in any related risk. Otherwise, it would be more heavily regulated.
Great. Thank you.
Yeah. No, thank you for chiming in with questions. And thanks to those of you that are asking them. So, so we know that these opioids can cause a real problem that we are in the midst of facing. And so I'm going to talk a little bit about addiction, and specifically as it relates to dopamine. So the term addiction comes from this Latin term addicere, which means to bind or enslave. How fitting is that? We can become addicted to many different types of behaviors. Some of these could be surprising to you. Some of them may not. Internet gaming, shopping, work. I'd have to wonder why someone would get addicted to work, but gambling, certainly. Living here in Nevada, we know that gambling behaviors can begin to become problematic. Anyway, we have a great and a tremendous capacity to become addicts because of the physical and anatomical makeup that we have. So more specifically, as we talk about opioids, I'm going to have a little bit of fun for a couple minutes in helping us understand what it's like to become addicted and understand the neurobiology. But I'm going to use a teenager's brain as the example. And so there's just some funny cartoons here of the anatomy of a teenager's brain. The Super Turbo Rebellion Center. Boy, we all have a little bit of that, don't we? Memory for music. I kind of enjoy this: love for parents and disdain for parents. This is not the only author who's had some fun with that. Here's a cover of the New Yorker. Again, another example of a teenager's brain. Sleep, first love, self-control is under construction, and that's going to be where we're headed to understand addiction, not just in adolescents, but in adults, in us too. So here's some work that was done by Paul Ensel, and this shows the developing brain, but it uses some colors. So the cooler colors like blue and purple show areas of the brain that have matured. And you'll notice this line right here in the middle. This is human ages 5 through age 20. And what you'll notice is that as we age, all the way through into our late teens or early 20s, our brains are continually maturing. These warmer colors, yellow, orange, and red, depict areas of the brain that are immature in a neurobiological sense. So here's the same type of graph, but now it's going to explain a little bit of how the brain matures through our adolescent development. Again, on the x-axis here is just age. Prenatal is over here, so this is in the womb, brain developing in a fetus. Here, 0 depicts birth, and then age through years all the way through 25 and above. The y-axis is the percentage of maturation, essentially, up to 100%. So 100% would be a fully mature part of the brain. Now, what's depicted in this graph that Dr. Insel pointed out is that early in development, there is a rapid maturation of excitatory synapses. These are neurons connecting in such a way that they can excite or activate one another. And if we make a vehicle analogy here, this would be essentially if your child's car was that would be scary. If your child's brain were a car, they develop the gas pedal first. They learn how to accelerate. On the bottom here, you'll notice inhibitory synapses. So these are synapses that allow for more decreased activity. And you'll notice that they develop much later on into later adolescence. So again, if in our car analogy, this would be like having brakes or maybe even a really good and effective steering wheel. So can you see with me the irony here that in our natural, normal neuronal development, we gain the ability to be more excitatory first before we gain significant ability to be inhibitory. Now, how that translates to our behavior is shown in this, again, a simplified slide. On the left is an adolescent brain that's still undergoing maturation. On the right is an adult brain. So our adolescent brain is excitatory. It likes to be excited. That manifests itself with significant influence of parts of the brain that control emotion, like our limbic system, and reward. Specifically, the nucleus accumbens is a brain region that underlies a rewarding or euphoric or pleasant feeling. The adult brain that's more mature is more thinking, reason, and judgment. We have these inhibitory synapses in the frontal cortex. Now, again, in keeping with our car analogies here, the adolescent brain is a little bit more like a sports car, impulsive and reward seeking. Our adult brain is much more deliberate and reasoned and controlled. This impulsivity and reward seeking is our adolescents or children that are wanting novelty. Now, how do we understand that in terms of addiction? Here's another image of the brain, and we're going to talk about who's in charge. You can fill in this with your favorite executive officer if you have one. I've just picked Steve Jobs here. So as we talk about the parts of our brain that really dominate in terms of decision-making and behavior, as we transition from adolescence to adulthood, we see our CEO really shift from these reward centers and emotional centers of the brain toward the prefrontal cortex. Again, this is natural development transitioning from adolescence into adulthood, neurobiologically speaking. Now, an interesting way to think about drugs of abuse, like opioids or drugs that can be abused, is that sometimes even as adults, they can turn us back into teenagers. significantly through the stimulation of what's this little brain region called the nucleus accumbens. There is a neurotransmitter, dopamine, we talked about it earlier, that has many functions: motivation, exploring and novelty seeking, habits, learned behaviors. It plays a role in all of those, but really this idea that it helps us to feel rewarded. That's a normal, healthy, appropriate function of your brain related to your behaviors. So unfortunately, drugs that have a propensity or a likelihood to be abused artificially stimulate that part of the brain and cause a spike or release in dopamine. It results in that rush, right? The feeling of euphoria. It's a shared characteristic of many different types of drugs of abuse. And that's shown here. Opiates obviously are included here, but it's not limited to that. It can be many, many different substances. They seem to share this property of being able to artificially and powerfully stimulate dopamine release in the nucleus accumbens. Now, what does that mean? So here's a PET scan of a person, and while they are receiving an infusion, in this case of cocaine. So on the right is in time, in minutes following that infusion. And while that's happening on the left, we can see the imagery of the activity of that part of the brain. And what's shown here is the nucleus accumbens. So now the warmer color here, for example, shown in red, is increased activity of that region of the brain. And if we're looking just at the nucleus accumbens, we see that there's this tremendous increase in activity following that infusion of cocaine to that person. That correlates very, very closely with the release of dopamine in that area of the brain, the nucleus accumbens. Again, it's that short-term rush or euphoria. Now, unfortunately, there's more to it than just that. There aren't just short-term changes in that part of the brain, there are long-term changes. And this is what we would call drug-induced learning. So this is an example from a laboratory of an animal that, this is a neuron, and these are projections that we call dendrites. In our modern way of thinking, it's almost like this neuron has little USB cords that go connect to other neurons. And they connect through these, this is a close-up of that same neuron, these spines that are almost like USB ports. And again, they allow neurons to talk to each other, to communicate. What you see in this middle box is the normal number of dendritic spines on the neurons in this animal. And then after this animal has received multiple infusions of cocaine, and this would be the same if we were using an opioid that is abused, like, for example, morphine or oxycodone. It increases the number of dendritic spines in the nucleus accumbens, which means, Vanessa's back, so it means we have a question.
Thank you, Dr. Talbot, and excuse the interruption. This is a question about brain development. And so you were talking about the infant brain developing. The question is, does the young brain, both male and female, mature at the same rate and in the same way based on gender?
Oh, what a great question. Again, the short answer is no. They don't mature in exactly the same way. And in fact, that's reflected more and more in research that we do, where there's a focus on looking at sex differences between maturation between males and females. Mostly, we can answer the question yes, but not in every way. We don't have a good understanding. I certainly won't speak to it. We don't have a good understanding of what those exact differences are, but we do know that there are differences between sexes in the response to opioids, for sure, both in terms of the inherent sensitivity to pain, tolerance to pain. And this is where many in the audience would maybe have reality be funny, which is women have a higher tolerance to pain than men. We are wimps in relative terms, and some of that can be drawn back to neurobiology.
Great, thank you.
You bet. No, good questions. So the result of this dopamine release in the reward centers of the brain, like the nucleus accumbens, is that we increase the neuronal input to those regions, which means our CEO, where we used to be as an adult, having most of our, or the predominant influence in the frontal cortex, reason, judgment, risk-taking in terms of being cautionary. It really comes back to where we were as adolescents, where we have more neuronal input now to the reward centers of the brain, which means even as adults, we kind of turn back into teenagers, more reward seeking, novelty seeking, impulsivity, risk taking, not appropriately assessing the negative consequences of our behavior. This begins to explain why addicts and why addiction is such a powerfully negative effect in our central nervous system. The addict begins to engage in behaviors that can result in self-harm or harm to others in such significant ways. So that's our little crash course in opioid pharmacology, understanding what the medications do, as well as opioid neurobiology, understanding how we can become addicted. We've talked about how we got here, the history of opioid use and addiction. We've talked about what the drugs do, and now I'm going to spend a few minutes talking about how our current crisis is evolving. This, what's known as this third wave of fentanyl. So what's the problem with fentanyl? Fentanyl is a drug like morphine. It's an opioid. It binds to the same receptor, the mu receptor in the brain and spinal cord and other parts of the body. It's unique though, in a couple of ways that are helpful therapeutically. It's highly lipophilic, which means it likes to be in fatty areas like the brain more than it likes to be in liquid areas, which means it gets into the brain really, really quickly. In fact, it works so quickly that we can use it not just as a pain reliever, an analgesic, but we can use it as an anesthetic. Now, that's the good. What's the bad with fentanyl is, it has properties that are not helpful illicitly. It's extremely inexpensive to synthesize. It's very cheap to make chemically. I'll talk more about that in a minute. More importantly, it is 50 times more potent than morphine. Now, in pharmacological terms, potency doesn't mean the power of an effect necessarily. It means how much drug does it take to achieve an effect. So 50 times more potent than morphine means that it takes 50 times less fentanyl to achieve the same effect as morphine would. And this is depicted here on the right, where you see actual heroin, fentanyl, and a fentanyl derivative called carfentanil in vials. And you can see that there's different amounts. What's shown here with heroin is this is the amount of heroin it would take to overdose for an average adult male. This is the amount of fentanyl it would take for the average adult male to overdose. And then finally, carfentanil. This is the amount of carfentanil it would take for the average adult male to overdose. What you see here is that it takes so much less fentanyl than heroin to OD. And that's the result of it being 50 times-ish more potent than morphine-like drugs like heroin. And carfentanil is 10,000 times more potent. So as a result, the illicit use of fentanyl is now a leading cause of opioid death. And that's what we'll talk about now is this third wave. Remember, it takes so much less. So first, on just some data to show you on the left, this is the number of deaths in tens of thousands in the United States. What you see here on the x-axis is just time by year. So we're going from roughly 2001 through 2017. So the gray bar is the number of deaths attributed to firearms. So we can see that they have increased, and unfortunately this little blip here is attributed in part to suicide. Motor vehicle accidents has been up and then down and then up again, this dark gray line. What's in red is the number of opioid-related deaths. This is all opioids together. And you can see that they have increased significantly. That's part of the crisis that we've been talking about today. At the same time that opioid-related deaths have been increasing, the number of opioid prescriptions, because of enforcement measures, is now decreasing, and that's what's shown here on the right. So this is the number of prescription opioids that are sold per 100,000 people. And you can see that through the early 2000s into 2010, it increased, and now it's been decreasing. So with decreasing prescriptions, we are still seeing increasing opioid deaths, which suggests there's a non-prescription problem. And that's what's depicted best here in this slide. So this is on the y-axis is the deaths per 100,000 people of our population in the US. On the right is years going from 1999 through 2018. So these are very recent data. And now what we're seeing, this graph, by the way, depicts three different types of opioids, or rather deaths attributed to three different types of opioids. In purple is our commonly prescribed opioids: morphine, oxycodone, or Oxycontin, hydrocodone, or Vicodin. Methadone is included here. In this yellow or orange line depicts the increase of deaths associated with heroin, which is not a prescribed medication. We don't use it medically at all. It really only is an illicit drug used in abuse situations. And then finally, in black are the deaths attributed to what we call synthetic opioids, and this would be essentially fentanyl or fentanyl-like drugs. And when the data are parsed out this way, what you see are three different waves of opioid deaths. We saw through the 1990s and early 2000s an increase in prescription opioid-related deaths. As we started to enforce nationally more laws and regulations around the prescribing and use of prescription-related opioids, they became very expensive on the street to buy illicitly. Let me give you a quick example, and I'll be brief. It costs between $2 and $5 to make a pill, a single pill of Oxycontin. On the street, that can be sold, that same pill can be sold for as much as $80 to $90. Now, the increased cost on the street is in part the result of improved enforcement. They're just harder to get, so they're more expensive. But we had a lot of opioid addicts in the US at that point. So as the prescribed medications became more difficult to get, more expensive, where did those addicts go? This table or this figure would tell us that they went to heroin. So people who started using opioids, started misusing opioids as a prescribed medication, went to heroin on the street, where you can buy a hit of heroin for as low as $30. Now, let's talk about fentanyl. So we've seen the deaths associated with prescription opioids level off. We've seen the deaths associated with heroin level off, but look at the increase in the deaths associated with fentanyl. Right now, this is the third wave. This, unfortunately, is the new evolving opioid crisis. Now, remember, we talked about one more point to make here. This is the similar data, just shown again, that on the left in red, the deaths associated with fentanyl are increasing, while the deaths associated with prescription and opioid drugs now are beginning to decrease. This figure on the right, without explaining in great detail, just shows the first opioid drug that's misused by a person used to be almost entirely prescription opioids. They were the gateway drug. If you were going to be an opioid addict, the vast majority of cases, you started by misusing the prescription, the OxyContin, the Vicodin. But what you see in blue is individuals who started their opioid misuse with heroin, skipped the pill, the prescription altogether, and just went straight to heroin. That is increasing. It's crazy to even say, but heroin is becoming the new gateway drug into opioid use disorder. The fentanyl-related overdose deaths by age, just a quick point that the predominant age groups that are affected are young adults into middle-aged adults. That's shown very clearly there. I wanted to include some Nevada data. This is from 2018 and 2019. These are the fentanyl seizures either by pills or by powder. And you can see 2018 is in blue, 2019 is in orange. And you can see that there's been a near doubling of the seizures of fentanyl pills here in the state of Nevada. This is hitting home for us, particularly in Southern Nevada, but also our rural communities that I'll talk about here in a moment. Couple of other points here to make about this fentanyl third wave. Remember, I told you that fentanyl is extremely potent, which means it takes very, very little fentanyl to achieve a potentially toxic effect. This is just a quick screen grab of a CNN article. This is from an officer, I want to say in West Virginia, I believe. It was in Appalachia. Participated in a drug bust, got back to the station and noticed a white powder on his uniform. He, with his hands, dusted the powder off of his uniform and within minutes collapsed. Fentanyl is readily absorbed through your skin, and it takes so little to achieve an effect. In fact, there are anecdotal reports of drug dealers who are lacing business cards with fentanyl powder and putting it under the windshield wipers of police cars so that an uninspecting law enforcement officer can pick up the business card and potentially receive a fatal dose of fentanyl. Now, one of the problems of fentanyl is that it's very, very potent. It takes so little to achieve potentially a toxic effect. But another problem is that you can make it very cheaply. This is from an article in the Wall Street Journal. I've put in quotes here, criminal chemistry, in part. That was their title, and I want to give them credit. But it really depicts in simple terms how, I won't say easily, but how cheaply fentanyl can be made as a fully synthetic opioid. So really what we're talking about is this key ingredient, NPP, purchasing 25 grams, by their calculations, roughly $90. Some other chemicals below 800. So under $1,000 can result in 25 grams of fentanyl being synthesized. On the street, value nearly $1 million. More importantly, the number of pills that can be made that can be toxic to our kids, to our family members. It is such a big deal. I've got a couple of slides here that for time I'll just really breeze through. This just shows that most of the fentanyl is coming from China, where it is either directly made, synthesized, and illicitly brought into the United States, or precursors can be made where it can be entered into Canada or Mexico, where the synthesis process can be finalized before it's brought into the US. And this second figure here, I included really solely to draw attention to here in Southern Nevada. What we worry about, particularly in Clark County, is the result of a product that is brought into Mexico and coming up through the San Diego area and up through I-15 moving north. So that's our third wave of opioid deaths attributed to this highly potent and very cheaply made drug, fentanyl. Let me close our talk today by just highlighting some efforts from our Roseman researchers to combat opioid drug abuse here in Nevada. I'll just talk about this briefly. This is the work primarily of Dr. Crystal Riccio of our College of Pharmacy here in Southern Nevada. I need to give a shout out to Vanessa, who participated in this work along with several other investigators. Dr. Riccio, in collaboration with investigators or researchers from the University of Michigan, developed a survey instrument for adolescents. It's termed the Secondary Student Life Survey Nevada, or SSLS Nevada, and it's really targeted for kids grades 6 through 12, so middle and high school aged kids. It's administered on a device like a smartphone or a tablet or even a laptop, though most kids preferred to take this on their phones. This survey was endorsed by the Nevada Psychiatric Association, the Nevada Psychological Association, multiple community partners. It was a very collaborative effort by Nevadans for Nevadans, and it's received some national attention for its ability to ask very specific questions related to all types of drug abuse, but specifically opioids, prescription opioids. These are some data. We piloted this in 4 Nevada schools, 2 in frontier rural communities, and 2 schools in Clark County. You can see that kids that had the opportunity to take the survey, nearly all of them completed it. It didn't take very long, just a few minutes, 23 minutes. You can see the breakdown of the respondents. Roughly 1,000 kids took this. Some of the key findings that we found, or Dr. Riccio found, one is that kids who perceive that drugs will not be harmful to them are more likely to abuse them. And that is especially true here with pain medications. These are our prescription pain medications, like the drugs that we've been discussing. Again, as they have a perception of less risk, they are more likely to misuse that medication. Another piece of data, just very briefly, that we have found extremely valuable to the state of Nevada is the difference between drug abuse trends in rural frontier communities versus metropolitan communities like Clark County. Dr. Riccio and her colleagues found that rural students were more likely to report misusing their own prescription drug. So if they were prescribed an opioid pain reliever, they are more likely to misuse that than to misuse the opioid that they've gotten from somebody else. That trend is exactly the opposite in urban students, for example, Clark County, where we found that students were more likely to misuse a prescription pain medication that they got from somebody else. It wasn't their own. They weren't misusing their own prescription. They were illicitly using someone else's. Again, some of the great work that Dr. Riccio has done here over the last several years in Nevada. And it's findings like this, it's research like this that can help us better develop and target substance abuse prevention messaging to our youth to understand what they are using and their perceptions of risk associated with that misuse. Now, one of the implications of that I wanted to make sure to include for this audience tonight in these last few minutes is I've kind of had fun with it, dealing with the dealer. Some of our findings, along with other researchers nationally, now most of our adolescents, our teens, are abusing prescription drugs like opioids from a family member or a friend. And so this dealing with the dealer really means each of us as individuals. We need to look ourselves in the mirror that we may unwittingly be the drug dealer, providing access for these very powerful medications to our youth. Vanessa, did you have a question?
I did not.
Great, I'll keep going. So just a couple of pieces of data. This pie chart on the left shows that roughly 65 to 70% of opioids, prescription opioids, are obtained from somebody else. That's the generic data. This figure on the right just reminds us most, or I should say many opioid prescriptions are targeted or given to our elderly appropriately for treating pain usually, or other maladies. But gosh, we have to be aware that these drugs can sit back in our medicine cabinet. And when we have nieces, nephews, grandchildren that come and visit us, they can be more attuned than we are to the abuse potential of these medications. So another initiative that Roseman has been involved with is helping support our community members dispose of these unused prescription medications like opioids. And through work with a drug company, Mallinckrodt, we've obtained tens of thousands of these drug disposal bags. If we were doing this in person, I'd hand some out. If any of you are interested, if you're a part of our Roseman family or just in the community, you're welcome to come by campus and we can give you some of these bags. They can safely be taken to any home it's a pouch that contains inactivated charcoal. Open up the pouch, put in the medication, whether it's pills or a liquid or even patches, and many opioid pain relievers are used as patches. Add in some warm water, seal it back up, shake it, and it can be disposed safely in your trash at home. It inactivates the drug. These are useful not just for drugs that can be abused. Any prescription medications that you want to safely dispose of can be done this way. Again, some efforts of Roseman researchers to help improve our Nevada and Utah communities. I'll close. I'm not going to read through this for sake of time. I think it's an interesting question for all of us to ask. Am I an addict? These are the clinical criteria. I've adapted this from the American Psychiatric Association and DSM-4, which is a psychiatric manual. I won't read through all of these, but the clinical criteria of addiction are, it's interesting to consider our own behaviors. Are we an addict? Certainly as it pertains to medications, but also to any of our behaviors. And then I'll end with this question, who me? It's estimated that over 20 million people need but are not receiving treatment for drug addiction. And of those, the vast majority of them, 95%, feel that they do not need treatment. I've included a slide here with some community resources. This is not an all-inclusive list, but ways that, that we can find help for ourselves, for our families. With that, I'm so grateful for your attention and for the opportunity to present to you tonight, and I'm happy to answer any additional questions, and especially a shout out to Samantha, who has been magnificent in translating this evening for some technical things.
Just a reminder of the question and answer and chat function in your bar at the bottom of your screen for any questions. Okay. We have a question. Are mail order pharmacies allowed to mail opioids?
Well, that's a very context dependent question that I would, in normal instances, defer to some of my colleagues in the College of Pharmacy. I'll need to get back with you for a more sophisticated answer. There are state-specific statutes that are beginning to govern mail order, and that's kind of a changing landscape. Yeah.
Okay, we'll give it a minute, see if we have any other questions. How do we help people, Dr. Talbot, who truly need these pain medications?
Isn't that an interesting question? You know, one of the lessons that we're learning historically is the reaction to increased abuse and misuse can at times exacerbate problems or have unintended consequences. And we are right now seeing that play out with the increased enforcement, the increased regulation of prescription medications like the opioids is making it more difficult for people to be effectively treated for moderate to severe pain. It's going to continue to be a challenging environment as we try and work through this nationally. I think it's the more direct answer to the question is rapport and communication with your healthcare professionals, including your pharmacist, maybe especially your pharmacist, as they know you and as they understand the problems that you're facing. That is, I think, by far the best advice, having that personal relationship with those caregivers to make sure that pain is being appropriately and effectively treated.
Great. I have a question related to addiction and treatment strategies. How are treatment strategies different for teenagers versus adults?
Well, kids do whatever you tell them, right? Mm-hmm. So we can just tell them. So there are many commonalities. We're finding we have good data suggesting that when in severe cases of not just opioid use disorder, but any drugs of abuse. Sometimes pharmacotherapy can be helpful in helping to withdraw individuals off of these substances. You know, mature, that's the wrong way to say it, really developed addictions have individuals using substances as much to prevent withdrawal effects as they are trying to get high. And so medical supervision and sometimes medications can assist with that, but certainly taking advantage of what we would call talk therapy and other, at times, very intensive, sometimes even inpatient therapy options can be helpful. That's true for adults and adolescents. It may even be more important for adolescents given the developing state that they're in. Great question.
This is an interesting question. You mentioned sort of these cycles of stigma and then undertreatment throughout history.
Yeah.
How has the lexicon changed throughout time to really kind of use more supportive language to reference these diseases, substance abuse, disorder, addiction?
Yeah, what an excellent question and insight. Although, you know, we didn't go into that as much today. In recent years, and I'll say within the last 4 to 5, maybe a bit longer, but it's really gaining momentum, would be what we would call harm reduction in terms of the language used to describe addiction. More importantly, the language used to describe addicts. A better recognition that addiction is not a character flaw. It's not, it certainly is not that simple. This is a neurobiological response to medications. And how we talk about it can help inform how we work with individuals to improve their lives and hopefully change their lives. That harm reduction has been a significant effort in recent years.
Take another question if you're not too tired.
I'm good.
Okay. How effective have prescription drug monitoring programs been in curtailing opioid misuse?
Yeah, it's again, very good question. They're being effective, and the number of prescriptions for opioids is decreasing. And part of that's doctor shopping, right? So it helps reduce that. I work with some folks who train DEA agents, and there are considerable efforts, not just prescription monitoring, but also registration in terms of making sure that people are less able to illicitly obtain these medications. Yeah, anyway. It's a long answer, but yes, it's working. The opioid prescriptions are coming down. We need to get on top of the fentanyl problem. If we could, then opioid-related overdose deaths, we could potentially see decrease as well.
Okay, I'm just going to give you one last question. And the last question is regarding the youth substance abuse questionnaire and research that you have in the field right now. Is that looking at alcohol abuse as well?
Yeah, it's although I chose for the purposes of this talk to focus on data that dealt specifically with prescription medications, really all substances that adolescents are likely to misuse are included in as part of that effort. And again, I just want to give credit. That's the work of Dr. Crystal Riccio as the principal investigator or the primary researcher. Alcohol's included.
Wonderful. Well, thank you so much, Dr. Talbot, for this incredible presentation and for all of the great questions from our guests. I just want to give you a quick reminder that on speakers.roseman.edu, you can also find a recorded version of this webinar as well. And to please look out for December 10th, funding higher education, and January 21st, we'll have an update on COVID-19 treatment and vaccines and development. So with that, we wish you a very happy and safe evening and a happy Thanksgiving as well.
Thank you, Vanessa. Thanks, everyone.
Thank you. Good night.